from a toxicity standpoint, it's a really interesting molecule because almost all the tox is early on. To your point earlier about cytokine release, we hospitalize patients, or at least we observe patients for 16 hours, but we do the same as you do, Dr. Hamid. We hospitalize patients for an observation and then send them out the next morning. But we do that only for those first 3 visits because the cytokine release syndrome doesn't really seem to be that big a deal after that. And in fact, once patients are on this for weeks at a time, 5, 8, 10, 15 weeks, it's like the easiest drug to give. Patients come in, they get treated. I don't know if you have the same impression, but
yeah, I would tell you that I agree with that, and that clinical trials bear this, that there was very few percentage of patients who discontinued the study therapy for a side effect. What's important is to understand the cytokine release syndrome, because this is new to most of our colleagues.
Yep.
It shows up with fever, fatigue, vomiting, chills, hypotension, hypoxemia, headache, dizziness, and it can be, the grades are very low, if you have some mild fever and mild shortness of breath, to very high, where you have someone who is in an immune type of flare condition where you need to use something like tocilizumab, but that's been very rare for us. We've seen some of that in patients who are adrenally insufficient because they can't mount that, and you can support them with hydrocortisone or others. But once you're aware of this and you can manage this side effect, the rest of the side effects, such as the rash and the fevers or the periorbital swelling that you see, are very manageable. You can see abnormal liver function tests, itching, some nausea, but other than that, it's very easy to manage that and very easy to manage prophylactically. And in some trials, they're even giving some early steroid before giving the infusions. So for me, I agree with you. The rash and some of those are only seen initially and then they resolve. And we monitor them with, just blood pressure, pulse, their oxygenation. Similar to anyone else who'd have like an infusion reaction. What we've known and what we've seen are that one-time doses of corticosteroids to treat adverse events don't really impact the overall survival, and that was presented at ASCO. But clearly, just like with checkpoint inhibitors, when you're giving them for a side effect, they don't affect outcome. And so it makes a lot of sense. So now when you're thinking about, well, is there a patient population for which you would not consider Tebentafusp? I would say it's someone who would really have a life-threatening event if they had a cytokine release syndrome, whether it's cardiac insufficiency or pulmonary insufficiency, but I've rarely run into that type of person. It might be someone who has a poor performance status that can't handle a setback of a toxicity, or someone who has autoimmune disease. But there's a rare findings in this population.
Just a quick note about toxicity. I agree with everything about cytokine release. The other thing you mentioned early on is the other toxicity that we see is rash. And it's a weird rash. It's like total body. You think that the person needs to be in a burn unit, right? Because they become really red really quickly, and it's terrifying. And they get swollen. You're like, there's this person, needs a burn unit and is going to die of this rash, and it doesn't happen. It just gets better, and you can use topical therapies. We use a ton of antihistamines, including dexofenadine is probably our go-to to try and help prevent the rash and the itchiness that's associated with it. But mostly it's just teaching people, including patients, you're going to turn red, and it's okay. And then you're going to go back to your normal hue after 24 or 48 hours of initial treatment.
I think that's the point to make, that usually the rash and the erythema are short-lived. The only issue is it's itchy, and it resolves Sometimes we see that overnight in the morning when I see the patient, and by the time the afternoon I see them in the clinic or the next day, it's already gone.
Yep.
And we utilize some preventative, which maybe some H2 inhibitors or some Benadryl, and it's really manageable.
Yeah, it is. But I think that's the first time you see it, it's terrifying. It's absolutely, because you're sort of this paradigm of total body erythematous itchy rash. This doesn't sound good. Rapid onset, right? But I think that it's important to note that the reason we give this drug weekly is it doesn't stick around very long, right. And so those toxicities actually dissipate quite quickly.